Welcome back to part 2 of this Burning Questions on All Things Coagulatory podcast. The remaining questions I put to our guests Rob Goggs and Lynch were revolving around viscoelastic testing and the use of antifibrinolytic drugs such as tranexamic acid. This was fascinating to record, and I hope you find it as useful as did I. So, back to the questions. Tell me, how do you use, if you do, how do you use viscoelastic testing clinically? Which animals are you testing, and how are you using that information? You know, we used to have TEG, maybe Rotem, and now we've got more cartridge-based systems, but the principle is the same. Do you use them? And if so, how?
The principle is the same. The tests are not.
Yeah.
Mm.
That's a different question.
I would say historically I worked at places where we've had a TEG, so thromboelastograph. 98% of a guess has been dog, like we very rarely do cats. But kaolin activated, recalcified, sort of on citrated whole blood samples is sort of our kind of go-to clinically. And we've used them predominantly, probably 80% of the cases are for those situations where could this dog be hypercoagulable is the question. And I think over time we've started to play with it in other ways. There certainly was a surge of interest of hyperfibrinolytic identification, and then playing with what the best way to use our assays to identify that. Could we rely on, just our standard, kaolin activated versus do we need to add TPA into the mix to kind of get that answer? And I would say the third population, which is the smallest population, would be for our hypocoagulable dogs. I think that would be the least common in our scenario. So to kind of answer your question more directly, considering the question is often more of the hypercoagulable thrombotic sort of situations, I think the dogs that we've used them for have been dogs that may already be on our radar as being at risk of thrombosis because of their disease state, or potentially dogs that have exhibited some kind of symptom that we could blame on thrombosis, but maybe it's harder to prove. So I think a lot of our dogs that come in with non-progressive neurologic signs and, could it be a stroke sort of situation? I feel like we've done plenty of viscoelastic testing on those dogs, and I'm not sure it's necessarily always fruitful, in terms of sort of what the right plan should be. But is a much more straightforward test, I think, for many people compared to running them through the MRI. Um, and so I think it can sometimes be a sort of a culture of we've got a test that might tell us that answer. It's pretty affordable, pretty easy to do. And so I think that's where viscoelastic testing kind of found a home in our clinic. Um, where you can scrutinize then is sort of how useful has that been? In my mind, separating at risk of thrombosis versus having had thrombosis, I think is important. If you can prove there's a clot there in some other way, probably through
Mm.
imaging, I don't know if a viscoelastic test is actually helpful.
Yeah.
I think that ship has sailed, as it were. Um, but if you are looking for clinical data to say, yeah, this animal actually could have tipped the balance where hypercoagulability is present, then maybe that's got a role. Underlying all of that, though, is can we feel confident in the result that we've had back? Sort of what other extraneous factors are going on? Can I explain this as being artifact for some reason?
Mm.
Do I feel that the test result fits the dog that's in front of me? And I think that's where doing more of them probably helps to have some sense of numbers behind you to scrutinize the results. But um, still, I think it can be they can be gray area cases often. And what you do with the extent of the maximum amplitude maybe is our kind of primary way of really assessing hypercoagulability on a thromboelastogram, how high does it really need to be for me to be worried? Rob, I'd be kind of interested to know your assessment, particularly from the benchtop side of things, really. Sort of where using a complicated assay to answer maybe unanswerable questions. you know?
Yeah, viscoelastic testing could be another day's worth of discussions.
Yeah.
So I'm going to pick up where I left off. So the assay platforms are not interchangeable. So I think just being cautious about saying, okay, I've got this result from a TEG 5000, or I've got this result from a Rotem Sigma, or I've got this result from an Integrion VCM. They won't necessarily be interchangeable.
Yeah.
Alex has already mentioned two different assay types on a single machine, right? So recalcified only and kaolin activated. Those are both primarily contact activation assays, and they would be separate from the tissue factor assays. And we have a range of different concentrations in the literature. So all potential variables, right? Some of the other platforms are more constrained about how the assay is configured, right? If you use a Rotem Delta and you're using the manufacturer's reagents, you're going to get the same assay configuration every time. That was one of the beauties of the TEG 5000 system for researchers, is that you could manipulate it by adding bits of TPA or inhibitors or drugs or whatever to answer different research questions. I think with regards to how it's used clinically here, it's really for the complicated cases where we're trying to integrate multiple different pieces of a picture. That maybe you've got a patient who has an increased fibrinogen, some degree of thrombocytopenia, maybe they are mildly anemic, their antithrombin is 57%, and you're trying to work out, okay, what is the overall integrated picture of this? What's their hemostatic potential? Are they more likely to have a thrombotic risk? Do they actually appear normal, that these things are balancing out? Or actually, am I more worried that the balance here is hypocoagulability?
Yeah.
And that's useful, I think, for these complicated cases, cancer, post-trauma, severe liver disease, where the picture is going to be complicated, but it's probably then used as part of a panel rather than as a single test. And that's, I think, one of the sad things for us who were super excited about the viscoelastic test. We were hoping it was going to be the one test that would, answer all questions. But if you look at the paper, it's a bit old now, but I think it's like JSAP from 2013. It's Natalie Bauer and Andreas Moritz, looking at patients they knew had thrombosis and not, and looking at a range of different coagulation assays. None of them were discriminating on their own. But when you start to add things together, like, okay, the G value is high and the platelet count is low and the fibrinogen is high and the antithrombin's this and the whatever, now you actually have a probably much stronger signal in this direction or that direction. And I think for me, who spends a lot of time working in the lab, that's great, because that's more business for us, right? More lab assays. But that's also the reality of interrogating a really complex interacting system, that it's going to be hard for any single test to answer every question. So I think we use it for those complicated cases where people are really trying to discern, should I intervene, and if so, with what therapeutic?
Yeah.
The analogy I kind of use for the residents often is, if our G value on a TEG, for example, is the equivalent of a pH on a blood gas, you still want your bicarbonate and your CO2 to sort of understand how it all kind of, where it's all coming from, what the clinical implications are. And I think you could argue, a fibrinogen and a platelet count to help interpret a TEG is actually very helpful. It just becomes very pricey all of a sudden.
Yeah. Yeah. Oh, yeah, and depending on where you are, may equate to some impossibilities in terms of matching
Yeah,
them up temporarily, right?
yeah.
Yeah. Very cool. Well, thank you very much. Yeah, I like those two perhaps overarching themes. So where you really don't know which direction this dog's going. Is it about to throw a clot, or is it about to jump off the DIC cliff? and you can get a little bit more clarity over that with a viscoelastic test, and then with the gauging the potential for a patient being genuinely hypercoagulable. Perhaps it falls back to those patients that we are talking about earlier, where consider thromboprophylaxis. Maybe you add in a TEG to try and build a case, but once the clot is present, yeah, I find us often, or we might be sort of asked, shall we run a TEG in this dog with a great big thrombus? Well, personally, no, don't really see the value in that. But yeah, great. Thank you for your thoughts. Okay, so we've got two. Well, maybe they're going to be quick fire. Maybe they're not. Questions to go. So, has your antifibrinolytic drug prescribing practice changed over the last few years, and how are you using antifibrinolytic drugs now? Because the background to sort of a bit of an intro would be that tranexamic acid turned up on the scene for a couple of reasons, right? The Crash 2 and Crash 3 trials years and years ago. Benefit was documented, used early in trauma, and then perhaps in mild to moderate head trauma specifically. And then also finding a niche in the use of tranexamic acid for managing patients that are genuinely hyperfibrinolytic, greyhounds post-op or post-trauma. But my impression is that seemed to snowball into a blanket prescription, and I bring the Smarties back in here because they were handed out like Smarties. Have you noticed a change? Has that persisted? Do you agree with that? If so, I guess I'm just stirring the pot here. How have your antifibrinolytic drug prescribing practices changed over time?
We should probably just, for our US audience members, indicate that Smarties are like M&Ms.
Oh, right, yeah.
I think there probably has been a change. I suppose personally prescribed them more when I delved into them, like you say, like read the Crash 2 trials, saw patient populations where plausibly they could help. Dabbled with trying to identify it with viscoelastic, as in identify hyperfibrinolytic tendencies on viscoelastic testing, and was often disappointed in not being able to identify it. And so moved away from testing to maybe, having that story of very sick with bleeding, likely needs transfusion support. So this seems like a reasonable thing to implement. And then I think I've moved, not to say I don't use them, but I probably reach for them less over time. And I think I would reserve them still for some of our, surgical cases, traumatic cases, but often the situations I'm using them for now are either specific breeds, right? So you've got the greyhound who's had, teeth extracted somewhere else and now they're oozing, after their procedure. Or places that are, maybe there's a wound or a mass or something like that that's causing bleeding, and it's really hard to get it to stop conventionally. And I've dabbled with, would this be a helpful intervention in those kind of cases? So maybe bleeding in an awkward spot, sort of those idiopathic renal hematuria sort of situations,
Okay,
sort
yeah.
of, would that be a scenario where maybe that could be helpful, where it's hard for me on a, emergency service sort of basis to do much without the ability to scope them,
Yeah.
Yeah, so my perspective is this is like lots of technologies, right? You have a few early adopters who see the potential and sort of start using things, and then everyone sees the possibilities and the rate of prescribing dramatically increases. And then after a period of time, it kind of plateaus out again, where people recognize this patient population probably benefits. It may not make any difference over here, and there's a risk of harm over there. And so you get this kind of, classic pattern of usage. And I think that's probably how it was with TEG, and how it has been with the antifibrinolytics. I think one of the debates that I don't think has been settled is, can you use them as a general hemostatic agent? right? Because for those patients where you can clearly document, and I would agree with Alex, it's relatively rare, you can clearly document hyperfibrinolysis is occurring. You can give the drug and you can see and document that it fixes the problem. But that's the minority. And so, are there situations where slowing the rate of fibrinolysis gives the forming clots time to be cross-linked by factor 13 to actually form in a more stable configuration, right? Because it isn't just about laying down fibrin, the actual rate, the concentration, and the flow dynamics of the forming clot affect the physical structure. And when you look at it, with the scanning electron microscopy, those clots look different, formed under different conditions. And so it's quite a complex system. And it may be that by slowing the rate of fibrinolysis under that scenario forms a more stable clot, and that actually enhances the overall hemostatic potential. But there's a risk, right, that if you give it to the wrong patient population, you may increase the chance of a thrombotic complication. And so the kind of classic question here is, okay, the splenic hemangiosarcoma that is bleeding in your ER, do they warrant, in addition to the transfusion and whatever else you're going to do prior to surgery, do they warrant an addition of one of these agents, either aminocaproic acid, which is more commonly used here in the States, or tranexamic acid elsewhere in the world? And if you're going to use it, when should you discontinue it?
Mhm.
Because those patients, we can document that they have, as Alex, I think, already mentioned, an increased risk of clot formation in the postoperative period, and their tumors often inappropriately express tissue factor, which shouldn't normally be in the intravascular environment. And so they are prothrombotic inherently. They present as bleeding because they are derived from endothelial cells, and the misformed vasculature just ruptures and bleeds everywhere. But on a more microscopic level, they're a thrombotic risk. And so there should be a tipping point at which you say, okay, bleeding has stopped. I'm actually going to take you to the OR and I'm going to discontinue your tranexamic acid at some point. And where do you draw that line? That's a difficult clinical question to answer.
I think, we've got several papers out there, sort of looking at applying it to different scenarios. Like Rob said, we've got a severe thrombocytopenia kind of case, or sort of a prospective. We've got a comparison of fibrinolytic tendency before and after splenectomy,
Mhm.
and just surgical hemostasis takes away the, fibrinolytic tendency. So, and also, trauma dogs where giving plasma is still a way to treat hyperfibrinolytic tendencies if it's there. So there's many ways to deal with it that are predominantly achieving hemostasis, either anatomically or through transfusions that, might negate the need to actually give these drugs at all. But I think on the clinic floor, it's really hard to recognize which of the, bad bleeding dogs you've got would benefit from it. And, back to the kind of renal hemorrhage scenario, like we've dabbled with it and then figured out we've caused ourselves a new problem because there's a big blood clot in the bladder now, and the dog's not peeing as well, and we've set up a further complication by accident.
Yeah, yeah.
I think what it argues for is a conscious, deliberate consideration of risks and benefits, the balance of the different parts of the system, rather than a if X then Y kind of blanket policy. Because I've certainly been guilty of, the recipe book approach. We all went through that kind of early goal directed therapy, period of time managing sepsis cases where they all got the checklist. But actually, being more discerning about what interventions in what patient populations at what time is probably the way to maximize the benefit, and just being more thoughtful about who, what, when, and how.
So do you think you can justify it so let's say you are primarily responsible for this bleeding hemangiosarcoma patient in the ER, are you gonna put aminocarboric acid on the kennel sheet or TXA on the kennel sheet?
If they're going to bleed to death, yes, because the urgent problem right now is hemorrhage. And I need them to stop bleeding long enough that they're going to be stable to go to the OR for me to definitively, or not me, a surgeon to definitively stop the bleeding. And if I can't get them stable enough to get them to the OR, it doesn't matter what happens in the post-operative period. So, where there's an urgent need for us to achieve hemostasis, it's part of that armamentarium. I think what I'm arguing for is being more, discerning about when you say, okay, I've achieved hemostasis, I've achieved my goal. I don't need to continue to provide this therapy for the next, week in the hospital.
Yeah.
And I think also to that extent, it's probably a pretty benign intervention in that scenario you described. But I do think there are other possible avenues of treatment that we may not pursue that I think you could argue for. Sort of, do these dogs have endotheliopathy and actually getting hemostatically resuscitating them as opposed to really relying on a ton of crystalloids to kind of get the job done? Would that actually be an early intervention that would be beneficial, appropriate, get you to the OR, get them onto the operating table faster and safer, achieve hemostasis surgically, and then, like Rob said, once you get through the surgery, they're probably going to do okay, unless the surgeon's indicating to you that there's ongoing oozing or something that's different about those dogs. So I think there's other ways to optimize early resuscitation of the bleeding dog. That could involve antifibrinolytics, but could involve other ways to do it too.
Yeah. I have to admit, I think we probably have stopped using a whole lot more tranexamic acid in those scenarios. So in that bleeding ER patient, I think I would see it a whole lot less on our kennel sheets than we might have done 5 or 6 years ago. I think we
Yeah.
I think that's one population in which we probably have dropped it right down. But I like the idea of making it a very conscious decision of saying, well, especially post-operatively, there's a extremely low chance, except for specific situations, that they're actually going to be of any benefit and potentially of harm, although we don't have the data to say that.
I think there's definitely a place for these agents. And just because we're sounding notes of caution doesn't mean they don't have a role.
Yeah.
Because certainly, the human studies that you mentioned, Crash 2, Crash 3, the woman study, it's a cheap, readily accessible intervention which saves lives. And I think there's definitely a patient population in our field where that is also true. It's just, as I described with the kind of rate of uptake, hopefully we hone in on the patients where we maximize the benefit and minimize the risk, even though the risk itself is quite small.
Yeah. And that's often going to come down to choosing when to discontinue, isn't it? Even if you do make the decision to start, right? Yeah.
And exactly like Rob said, for the septic dog, that's better. Like, he doesn't need to go home on clopidogrel. Remember that, these dogs with bleeding, if you achieve hemostasis, they don't need to be on these drugs for days and days and days. This is a dose or two, perhaps, but shouldn't be a day 2, day 3 thing,
Yeah. No, great. That's exactly, it's exactly the kind of specifics that I think have been changing a lot over time, or need underlining, don't they?
Yeah.
Yeah. Okay. Well, I mean that's us at the end of our burning questions script. So again, thank you so much for joining me. I've learned a huge amount. Thank you very much.
Well, thanks for asking us.
Talking
Yeah,
about,
great.
So the aim of VetLit is to make veterinary literature both more accessible and accessed, and hopefully we've secured that in some small way today, or maybe even in a bigger way than normal. But remember, you'll almost definitely find an article to read that interests you on the vetlit.org site. You can check back here, there, or via the email updates for more. And otherwise, have a great day. It's goodbye from Rob and Alex.
Bye, everyone. Thank you.
Goodbye for me. So bye-bye for now.